Hello dear students, this second session of Spotters and Boosters includes presentations in comparative slide forms to have adequate learning. The objective of this presentation include to promote critical thinking, application and synthesis for better understanding of these subjects in the pharmacology, to enhance performance in the Viva voce examination as students better prepared, and to crack MCQs correctly, and finally to enable IMG to select a drug as per the need of clinical. 1. Identify drug A and drug B used in Parkinson's disease. Drug A irreversibly inhibits key enzyme that inactivates dopamine centrally and peripherally. Drug B irreversibly inhibits key enzyme that inactivates dopamine in brain. Drug A prolongs the half-life of levodopa. Drug B have shown neuroprotective effects experimentally. Drug A reduce fluctuations and wearing off effects of the levodopa or co-levodopa. And drug B also reduces fluctuations of the motor movements. Drug A is not given usually in early Parkinsonism, whereas drug B is also given alone in early Parkinsonism. Use of drug A may result in discoloration of the yellow-orange discoloration of urine, and it may also worsen levodopa-induced abnormal movements, whereas drug B causes sleep disturbance, postural hypotension, and psychosis sometimes when used for a long time. Now, how do we discern these two? One student should have adequate knowledge from the book, prescribed book. Critically think. There are three enzyme inhibitors which are used in the treatment of Parkinsonism. Monoamine oxidase inhibitors, particularly MAO-B inhibitors, then catecholamic orthomethyl transferase inhibitor, and peripheral decarboxylase inhibitor. Now, looking to the picture given, drug A appears to be tolcapone because it is a COMT inhibitor that acts centrally and peripherally. Drug A is not entacapone, which is also another COMT inhibitor, but that is peripheral COMT inhibitor. Drug is not carbidopa, peripheral decarboxylase inhibitor, because it doesn't act centrally, whereas drug A is acting both centrally and peripherally. Drug A is also not MAO-B inhibitor because it has action in the brain only, whereas the suggested drug A has brain and peripheral actions. Therefore, our narrowing would be tolcapone. And if we review the text of the tolcapone, it can discolor the urine. So it confirms A is tolcapone. Drug B is monoamine oxidase B inhibitor that acts to inhibit inactivation of levodopa and dopamine nigrostriatal neurons. So it enhances the effect of dopamine there. It is not rasajalin because although it is monoamine oxidase B inhibitor, but only salicylic causes insomnia and anxiety due to its conversion into amphetamine as metabolite. Rasajalin is not converted. Therefore, it is monoamine oxidase B. Exercise 2. Identify antihypertensive drug A and B. A reduces blood pressure by peripheral vasodilation. B also reduces blood pressure by peripheral vasodilation. A is active by itself and is taken once daily. B is active but is more activated into a potent metabolite and is given once daily. A reduces formation of angiotensin II. Here it gives an idea where it is acting. B does not decrease angiotensin levels. A raises angiotensin 1, whereas B raises angiotensin 2. A causes hyperkalemia, dry cough, and dysgeusia, whereas these adverse effects are hardly ever seen with the use of drug B, but hyperkalemia is seen. A has no effect on uric acid levels. B has uricosuric action. A potentiates bradykinin, B does not potentiate bradykinin. And A is 100% excreted through kidney, and therefore dose adjustment is needed in renal disease. Whereas B is eliminated by renal and hepatic system, so dose adjustment may be required in liver disease. Now this clinical picture given points out to that the drug may be acting on renin-angiotensin system. A and B both will be acting on this system. How do we differentiate? Drug A is an antihypertensive that reduces peripheral vascular resistance and formation of angiotensin II and potentiates bradykinin. So these three things show it they are ACE inhibitors, PRILs. Since it is active by itself, therefore captopril and lisinopril are active. Other PRILs are not active. They must be activated. Therefore, either drug is captopril or lisinopril. But since it is 100% excreted unchanged and given once daily, it is lisinopril only. Captopril is given divided doses daily. It is to be remembered that all ACE inhibitors may raise angiotensin 1 level by negative feedback. Now, looking to drug B has also shares many of the actions but does not reduce angiotensin II levels and does not cause dry cough and acts like ACE inhibitors. So it belongs to angiotensin II receptor blockers or sartans. Since it causes uricosurium to some extent and is further activated to a metabolite, it is losartan but not other drugs. All ARBs may raise angiotensin II levels as compared to rise in angiotensin 1 with ACE inhibitors by negative feedback. Here we have not distinguished among the various sartans to make it simpler one to understand. However, if more clues are given, we can identify individual drug. For example, candesartan has higher affinity at 81 receptors, is longer acting. Irbesartan is eliminated by liver. Olmesartan is a ester prodrug. And telmisartan, no active metabolite is found, excreted in bile. Eprosartan reduces noradrenaline release also. If these clues are given, then we can identify these sartans. Third, identify drug A and B. A is useful in obstetrics to control postpartum hemorrhage. B is useful in obstetrics to induce labor at term. A increases force and frequency of entire gravid uterus. B increases contraction of the upper segment, whereas it relaxes lower segment. Uterine sensitivity of drug A increases as the term and during puerperium, whereas B increases force and frequency of uterine contractions during third trimester more than first trimester. A can be given by all routes, whereas B is given by IV infusion only. A reduces milk secretion, whereas B stimulates milk ejection, not secretion, but ejection by myoepithelial contraction. Blood pressure may rise, blood pressure may fall. So this is how there are two similar acting drugs with almost similar indications, if not same, but similar indications, but differentiation has to be made. Now, if we think critically, A can be ergot derivative, methyl ergometrin, which is given parenterally as well as orally to reduce postpartum hemorrhage after childbirth. It has multitude of actions which have already been described in the text. B is oxytocin because it contracts upper segment and relaxes lower segment, and it also increases milk ejection, and that is oxytocin action per se. It can also be used for postpartum hemorrhage. Now, since oxytocin does not raise blood pressure, it may actually fall because of some vasodilatation. Drug A or drug B cannot be prostaglandin analogs because PGE2 and F2 analogs contract pregnant and non-pregnant uteri similarly. show wide variations in uterine actions, soften cervix rectum, cause abortion, diarrhea, and abdominal cramp. None of these symptoms are described for differentiation. PGE2 may also reduce BP. PG alpha 2 has little effect or may raise BP. Therefore, this clue will not be helpful. Therefore, the answer is A is methylbromidine, B is oxytocin. 4. Identify drug A, B. A increases urine output by inhibiting sodium chloride co-transport. B increases urine output by inhibiting sodium potassium chloride co-transport. A is used in the treatment of hypertension along with other drugs, whereas B is mainly used in the treatment of left ventricle failure in edema and incipient renal failure. A is used to prevent recurrent renal stone formation. B is used to rapidly control secondary hypercalcemia malignancy because it increases calcium excretion. A is low efficacy diuretic, B is high efficacy diuretic. A does not inhibit tubulo-glomerular feedback. That's very important. Whereas B definitely inhibits tubulo-glomerular feedback. So reduction in GFR is seen with A but not with B. A has a longer duration of action, whereas B is short duration. One more difference could be A is given orally, B can be given orally or parenterally. Uncommon adverse effects are hypokalemia, hypercalcemia for A and hypokalemia, hypocalcemia for B. Looking to the clinical picture, both are diuretic acting on different segments. A appears to be a thiazide diuretic, either hydrochlorothiazide or chlorothalidone. It is probably chlorothalidone because of much longer half-life of the drug than hydrochlorothiazide. So A is chlorothalidone. The B drug is loop diuretic because it acts to inhibit sodium potassium chloride co-transport. It is furosemide because torsemide has a longer duration of action. Furosemide is effective IV for pulmonary edema because it rapidly causes venodilation. Now a word about tubulo-glomerular feedback. Increased delivery of sodium in distal convolute tubule activates macular denser cells to send signals to afferent glomerular arteriole of the same nephron to induce vasoconstriction. Therefore, it reduces glomerular filtration. That reduces GFR. This is a compensatory mechanism that is inhibited by furosemide but not by thiazides. 5. Identify drug A and B. A acts as an antagonist at mu kappa delta receptors. B also acts as a potent antagonist at mu kappa and delta. A is a pure opioid antagonist used parenterally. B is pure opioid antagonist used orally. A is used antidote for acute morphine intoxication. B is not used for this purpose. It is used for prevention of relapse in opiate addicts. BA has a short duration action, therefore it requires to be given repeatedly in acute morphine poisoning. A nasal spray and auto-injectors are also available. B is a long-acting drug, can be given once daily or once in 2 days. Special formulations are also available for once in a month intramuscular. A can be used for the diagnosis of acute morphine poisoning. B is not used for diagnosis of acute morphine poisoning. A precipitates withdrawal in morphine addicts. B is used in post-addicts after detoxification for reducing craving. This is called as opioid blocking therapy. Also blocks acupuncture analgesia and analgesia induced by placebo, whereas B is used to assist smoking cessation and to prevent relapse in chronic alcoholic. A is used along with buprenorphine for substitution therapy in chronic opiate addicts. B is used along with bupropion for weight reduction in obesity. And the B drug is hepatotoxic if we use longer. Now, it's a very clear picture that both are pure antagonists, but one is given orally, on another. So, A is naloxone, that is specific antidote for acute morphine overdose. B is naltrexone, which is used in post-Rx to reduce craving. B could also be nalmefene, but nalmefene is not hepatotoxic. So it is not nalmefene, but it is naltrexone. Identify drug B and B, an intermediate acting glucocorticoid, which is used orally. B is longer acting glucocorticoid used orally and parenterally. A has salt retaining potential greater than B. A can be used for the treatment of mother if glucocorticoid is indicated. For example, a pregnant mother may be suffering from collagen vascular disease or arthritic disorder requiring glucocorticoid, then A is better than B. Whereas B is preferred for antenatal use to prevent neonatal respiratory distress syndrome if premature delivery is expected. So, A is suitable for alternate therapy to reduce hypothalamo-pituitary axis suppression. B is not at all suitable for this type of use, whereas it is used for suppression test in the diagnosis of Cushing disease or Cushing syndrome. A shows concentration dependent protein binding, whereas B is only 70% bound to albumin mainly. A does not show any activity as antiemetic activity shown by B, and for this purpose B can be used to prevent or treat chemotherapy-induced vomiting. Now the picture seems to be very clear. One is shorter acting, one other is longer acting. A is prednisolone, because prednisolone is an intermediate acting glucocorticoid having some salt retaining activity and most commonly used orally for maintenance therapy. Prednisolone is safer to be used for the treatment of mother requiring steroids because it is metabolized by placenta to prednisone and does not reach enough quantities to fetus. B drug is dexamethasone. Dexamethasone is shown to have antiemetic action, therefore is used to treat and prevent chemotherapy-induced vomiting. Antenatal glucocorticoids are useful frequently in the setting of premature labor, decreasing incidence of respiratory distress syndrome in neonates. It also decreases incidence of intraventricular hemorrhage and death if delivery is premature. And for this purpose, betamethasone or dexamethasone is given, not the prednisolone. It is given to mother and sufficient amount crosses the placenta and reaches the fetus for maturation of the pulmonary surfactant. So these 6 key differentiating points will enable you students to critically think how to identify a suitable drug. Now there is a little homework for you and it will help you in cracking Viva also. Enumerate drugs that inhibit peripheral conversion of T4 into T3. An intermediate acting glucocorticoid that lacks mineralocorticoid activity. Prednisolone has both, but you have to identify another one. Name a drug that is inactivated by red cell esterase enzyme. Which fibrate is preferred to be used with rosuvastatin? Why it is so? Name a drug that is bound to red blood cells. Peripherally acting pure opiate antagonist used in postoperative paralytic LES. It is a peripheral acting. Mention a dual GLP-1 and GIP agonist developed as anti-diabetic drug but is also now promoted as weight loss agent in obesity. Which proton pump inhibitor would you use for a patient on clopidogrel? Give reasons. I am not giving answers to these queries. Please find out from your standard textbooks. They are very well given in all, and you may, if you want answers, then you must see the third version of spotters and boosters. Thank you very much.